Yes.
Okay. So we finished up hemodialysis last time, so I think we can segue straight into peritoneal dialysis. And we'll first talk about some of the basics, the principles that underpin peritoneal dialysis. I won't belabor some of the nomenclature. We should be owning this for the most part at this point in time. So I'll just zoom through this. CAPD refers to these manual exchanges that persist throughout the entirety of the day. APD is really basically cycler-based therapy. And when that cycler-based therapy is simply overnight, then we call that nocturnal intermittent peritoneal dialysis, NIPD. And when you have last fills that persist into the day, and certainly if you have a midday exchange, we call that CCPD. Tidal PD, I might slow down for just a bit because this is not commonly used, is a strategy of performing peritoneal dialysis in which you do not fully drain the abdomen with each exchange. So if we were to graphically represent the exchanges of tidal PD, at the initiation of therapy, you might put in 2 liters that dwells for some period of time. And then instead of taking the entirety of 2 liters off, we would take, for instance, 1.5 liters, leaving behind 1,500 cc's. That would be what we call tidal PD. Now, the percentage of the total dwell volume that we leave behind is prescribed. You usually prescribe that as 90% tidal PD would refer to leaving behind 10% of the dwell volume. Okay, so the usual nomenclature refers to how much that you take out. If you take out 90% and you leave behind 10%, that would be a tidal PD prescription with 90% of your fill volumes exchanged in and out of the abdomen. Why would we do tidal PD? The primary reason is addressing drain pain. Okay, some people, when they're fully drained, have this tugging sensation. It can radiate into the groin, feel like a kidney stone in essence, and leaving behind a certain volume will minimize that discomfort for those patients that experience that. There is theoretically the possibility of increasing clearance with tidal PD because you're essentially maintaining flux transport throughout the entirety of the peritoneal dialysis procedure, since the belly is never empty during the course of those exchanges in and out. But you end up having to use more total volume of exchange fluids. So, this is not a primary advantage, right? If you're getting more clearance at the expense of more total volume, that's not truly a advantage, right? Because you could achieve that same increase in clearance by increasing total volume. So this is less efficient. And so this theoretical increase in clearance from continuous fluid membrane contact is purely theoretical. You have to use more total volume in order to achieve those increases in clearance. The disadvantage, again, is the increase in dialysate that you must use, or increasing in primarily through increases in exchange number in order to achieve the similar amounts of clearance that you would do for more standard prescriptions. Okay. And then we don't ever do this, but we may approximate some form of continuous flow PD where you're really trying to maximize clearance and potentially ultrafiltration in a patient who's, let's say, critically ill, extremely volume overloaded. If you want to maximize the amount of clearance as well as ultrafiltration, you would do that by maintaining a constantly fresh, let's say, dialysate that has no small molecule toxins in it like urea or acids. So by continuously putting fluid into the belly and essentially taking it out continuously, you can maximize the gradient, the favorable gradient for small molecule clearance as well as ultrafiltration. So this might be something that you might consider. Essentially, if you were to do this, you would essentially put a patient on cycler. You wouldn't torment a nurse doing some form of continuous flow PD. You'd put them on a cycler. You'd put in, 12 hours of total therapy, and I'm going to do 12 exchanges over the course of those 12 hours, where you're essentially putting fluid in, taking it out immediately, trying to maximize the gradient for small molecule clearance or ultrafiltration in order to achieve the UF goals or the metabolic control that you have in this very sick patient. Okay, you will run into limitations because there is a certain amount of time that's required for putting fluid into the belly as well as draining the belly. So it's practically it's not really possible to do continuous flow PD with a cycler. Okay. All right. So moving on to principles of peritoneal transport. I will move pretty quickly through this because this is largely theoretical and doesn't translate in large part to a lot of clinically relevant aspects of PD, except if we start talking about ultrafiltration failure, we might talk about some of these concepts as we broach that topic. We describe peritoneal transport through models, mathematical models. Okay, this is a model. This is not necessarily a one-to-one translation to what is actually happening in vivo, but we describe transport in terms of solute transport and water transport across these theoretical pores. Okay, we describe them as large pores, small pores, and ultra small pores. Okay, what do these refer to? Well, these mathematical large pores would allow one to model how much macromolecular solute flux there is during the course of dialysis, peritoneal dialysis. For instance, we're removing roughly about 10 grams of albumin per day in a typical peritoneal dialysis patient. Okay, somewhere between, there's varying numbers, but you can round it off to about 10 grams per day of albumin clearance. And presumably this albumin is cleared through these large pores in the peritoneal membrane. Some of these large pores may refer to the clefts that exist between endothelial cells. Okay, so they're not really pores per se, or they're not necessarily mapping in vivo to specific physiologic structures, but as one attempts to do that, one can describe these clefts between endothelial cells as potentially the physiologic large pore. Okay, they're small pores, which allow the flux of small solutes and water. This really is the bulk of the peritoneal exchange surface. Okay, they are one can model the bulk of peritoneal transport through these small pores that have this functional size of 40 to 60 angstroms. Okay, sodium flux happens through these pores. Water flux happens through these pores as well. And then you have these so-called ultra small pores, which are really only able to transport water. Okay, and that is a small amount of the total peritoneal membrane surface. It is felt that aquaporins, you have aquaporins throughout the body, not just in the distal nephron. You have differing aquaporins in various locations throughout the body. Peritoneal aquaporins mediate the flux of water into the peritoneal lumen. But again, the small pores also transport a significant amount of water. Okay. So let's then move to the peritoneal equilibration test. That certainly has, I would say, more clinical relevance than talking about the 3-pore model of peritoneal transport. We perform these studies after a patient, let's say, hits stride in peritoneal dialysis, after they're initiated on peritoneal dialysis. We give them at least about a month before we perform a peritoneal equilibration test, and then once a year on average, okay? And the hope is we're describing the peritoneal transport characteristics in these various classifications. We have individuals who have so-called high transport characteristics, low transport characteristics, and these intermediate transport characteristics that are described with the following metrics. You can use the transport of creatinine or the transport of glucose to describe peritoneal transport characteristics. I would say the glucose method is, the more sort of commonly used. So what are we using to describe these peritoneal transport characteristics? We put fluid in the abdomen. The standard practice is to use a 2-liter fill of a 2.5% Dianil bag, okay? And then we sample the blood and dialysate at 2 hours and then at 4 hours, okay? And then you describe the concentration of glucose in the dialysate compared to time zero, or you can use these changes in dialysate creatinine concentration compared to plasma creatinine concentration to describe transport characteristics for the individual. You can see that when you use glucose, you need only sample the peritoneal fluid glucose, not the patient's glucose concentration. All right, so when comparing the dialysate glucose concentration at 4 hours, that is 240 minutes, compared to that initial dialysate glucose concentration, if an individual has high transport characteristics, you can see a reduction in the dialysate glucose concentration that is quite robust, right? Again, if I have high transport characteristics, then I have an individual who has their abdomen, the peritoneal fluid lies in the abdomen. If I'm using, again, a 2.5% dextrose solution, what is happening is dextrose is moving from the peritoneal fluid into the blood, okay? And so that dialysate glucose concentration is decreasing over time. If that dialysate glucose concentration, let's say, dramatically decreases over the 4 hours, that is, it decreases by, 75% or so, okay, you could describe that individual as a high transporter. If there's about a 50% reduction, only about a 50% reduction, then you would describe that individual as a low transporter, okay? So what does that mean functionally to our patient? How does that affect their therapy? Well, if you have an individual who has low transport characteristics, that means the dextrose concentration here remains relatively high, right? Over time, it decreases only a little. Let's say initially it has, let's say, 4 up arrows. Over time, it decreases to 2 up arrows. Then there would be a greater time for ultrafiltration to occur. That's water and salt to move into the peritoneum. So low transporters, perhaps unintuitively, have better ultrafiltration. Low transporters have better ultrafiltration. When I have an individual who has a more rapid transport, let's say that dialysate glucose concentration drops fairly quickly, then the amount of ultrafiltration that occurs is less. Okay, so high transporters have worse ultrafiltration. If you had to choose between one or the other, you would choose to be a low transporter. If a low transporter has less clearance of small molecules, right? They need higher dialysate volumes in order to achieve the same amount of metabolic control. That's because even though water more efficiently moves into the abdomen, the small solutes like urea are less efficiently transporting. Whoops, I should say, yeah, I should say that the urea concentration obviously is going into the dialysate, right? So urea is flowing into the dialysate, right? If I'm a low transporter, then that urea flux into the dialysate, the elimination of urea is less quick than a rapid transporter. So a low transporter has, again, less clearance, right? But more ultrafiltration. Now, it turns out that high transporters in multiple studies have worse prognosis. Okay. So you have to think about that. What is that? What's the deeper meaning of that? It means that these KT over Vs that we might slavishly try to pursue is probably less relevant than maintaining volume control in a patient. I made this point a couple of times. We think of uremic toxins in terms of urea and KT over V and maybe some phosphates. Don't forget, one of the most important uremic toxins is volume control. Okay, so hypervolemia is an important uremic toxin. That's why in CKD clinic, I think problem number 2 is always blood pressure and volume control, because volume control or hypervolemia and cardiomyopathies from hypervolemia is a uremic toxin. Okay, so again, if you had to choose between being a low transporter or a high transporter, turns out low transporter has a better survival compared to high transporters. Okay, so ultrafiltration capacity describes the ultrafiltration in a PET test over the course of that 4-hour period. If I have an ultrafiltration that is only 200 mils in a 4-hour PET test, then, and the patient is anuric, that would suggest that this individual is going to have problems with maintaining volume control. Okay, they would run into problems of chronic hypervolemia. So this is also something that can help you with managing the patients. We've already talked about some of the PET test parameters. Let's make a few other points. I'm describing this yin and yang between solute clearance and ultrafiltration. And then as a last point, we'll just talk about how this transport characteristic might drive your clinical decision making as you're describing or you're initiating peritoneal dialysis regimens. If I have a high transporter, you would want to minimize the time for equilibration between the dialysate glucose and the patient's serum glucose. So you'll do that by shortening dwell times. Long dwell times in a high transporter will result in negative ultrafiltration in some cases. Okay? Long dwell times in a high transporter would result in equilibration of that glucose in the dialysate quickly and eventually reabsorption of that fluid and glucose back to the patient. Okay, so shortened dwell times are the preferred approach if I have a high transporter. So NIPD would be an example of that, or CCPD with shortened dwell times. When I have a low transporter, you're needing, you can benefit from longer dwell times, okay, in order to achieve that continued urea flux. Okay, so longer dwell times would be my biased direction if I have a low transporter. Okay, still many low transporters can be managed with nocturnal or CCPD. They are generally going to require higher total volumes, right? Because again, when I have low transporters, I have less solute clearance. I have better ultrafiltration, but less solute clearance. In order to achieve the necessary metabolic control, then I would need to crank up on my total volumes, for instance, okay, by adding exchanges throughout the day, either through CAPD or through CCPD with midday exchanges, etc. Okay? All right. There is a modification to the peritoneal equilibration test in which you essentially use the same technique, but you use a different concentration of dianeal. There's a different definition for inadequate ultrafiltration when you use a 4.25% exchange. So the formal definition, I'm comparing and contrasting ultrafiltration capacity, which is done with a PET test with a 2.5% dianeal. It gives you some sort of clinical clues as to whether ultrafiltration will be sufficient. But if you want to make the, let's say, formal definition of ultrafiltration failure, that is done through this formalized approach of using a red bag and measuring the ultrafiltration after 4 hours with a red bag. And if it's less than 400, we would describe that individual as potentially having ultrafiltration failure. Okay? A more formal definition. Let's move on to prescribing. Correct. Yeah, the question is, the definition of ultrafiltration failure has nothing to do with transport characteristics. Let's use an example, okay? I might have a low transport characteristics, but still have ultrafiltration failure if I have catheter dysfunction, okay? Or if I have a hernia sac, okay? So those would be examples where it's not a membrane failure per se, but there is a failure in the technique that's resulting in ultrafiltration failure, okay? All right. But generally speaking, there is correlation between transport characteristic and ultrafiltration failure, right? But there could be other ways one can demonstrate ultrafiltration failure through these other, hiccups, okay? All right, and we'll get to that as we talk about ultrafiltration. Let me just sort of, anticipate this conversation. We're going to talk about complications of peritoneal dialysis, and volume overload is one of those complications of peritoneal dialysis. And you can see that, if you have insufficient ultrafiltration, I didn't use the term ultrafiltration failure here, but ultrafiltration capacity instead, you can see that there's, high transport characteristics as one example of low ultrafiltration capacity, but then there are these other things as well that can result in low ultrafiltration, okay? I guess I've avoided the term ultrafiltration failure in that section of the field guide, but you can see the analogy. All right, prescribing peritoneal dialysis. Catheter use, let's first go over that. In general, we start peritoneal dialysis about 2 weeks or more after PD catheter placement. However, if we need to, we can do urgent start peritoneal dialysis by using smaller exchanges if we need to. Okay, if we need to use the PD catheter the next day, it can be done. You would just need to start out with low volumes in order to avoid the peritoneal dialysis catheter leaks. Okay, the standard dialysate electrolyte content is provided to you. You can see that the sodium concentration in the dialysate is a little lower than quote unquote normal in order to ensure that there's a gradient for sodium flux into the abdomen. I glossed over a concept called sieving coefficient, but I'll say that, sodium sieving, not sieving coefficient. Sodium sieving refers to the ability for sodium removal to occur as a secondary process from the movement of water, okay? So you don't necessarily need a sodium concentration to be less than, let's say, dialysate sodium concentration to be less than serum sodium concentration. Okay. You don't theoretically need that in order to have sodium removal, because you may first have water that is moving into the dialysate. That water movement into the dialysate lowers the dialysate sodium concentration, and then creates a gradient for sodium removal. Okay, so that's called sodium sieving. Oops, sodium sieving. Um, and but in order to enhance sodium removal, we have a dialysate sodium concentration that is lower at 132. Okay, you can see that the base in peritoneal dialysate is lactate, 40 millimoles per liter of lactate. That's the same units of lactates that you measure in the blood. And so think about that as you're dialyzing somebody in the ICU who may have, severe metabolic acidosis, and a lactate that's already elevated. It's interesting to think about what you're doing when you're doing dialysis with a lactate of 40 millimoles per liter. That may be another conversation separately, but one can say that the net is a base load. Even giving lactate to an individual at 40 millimoles per liter to an individual with lactic acidosis can ameliorate a metabolic acidosis. How that happens, we can talk about separately if you're interested. The dextrose concentration varies quite significantly across the different dialysates that you're using. 1.5 grams per deciliter, that's grams, right? That's in comparison to the blood glucose concentrations that you're measuring in milligrams per deciliter. So this would be 1,500 milligrams per deciliter glucose concentration in the dialysate, allowing for a diffusive or osmotic gradient for water removal. Okay. Here are some rules of thumb for prescribing peritoneal dialysis. Okay. One can use some tools. There is a tool, I don't know if I invoke it here, but there's a tool called Adequest, where you can plug in some of the transport characteristics for your patient, their size, their residual kidney function, and get a potential peritoneal dialysis prescription for the individual. But you don't need that. You can also use your knowledge of peritoneal transport in order to devise a preliminary prescription. Okay, so initial dwell volumes according to patient size, these are rules of thumb, are provided. If you have a very small individual who's less than 60 kilograms, you might consider using dwell volumes of only 1.5 liters to avoid some of the discomfort that comes from abdominal distension and putting in larger volumes in your patient's abdomen. Okay. The dwell time we talked about as being affected by the transport characteristics of the peritoneum. Okay. Here's some actual empiric data that helps you understand this stuff. You can see that the urea concentration in the dialysate achieves the same blood urea nitrogen concentration that is in the blood at 4 to 5 hours in patients with low transport characteristics. Okay, so that means as you have dialysate in the abdomen of a low transporter, even at hour 4 and 5, there is still some urea that's moving from the patient into the dialysate. Okay, there's still not complete equilibration by 4 or 5 hours. After 5 hours, you can assume that the dialysate urea concentration has now equilibrated with the BUN of the patient. Okay. Now, if I have a high transporter, you can see that BUN has equilibrated with the dialysate urea concentration at 2 to 3 hours. Okay, so what does that mean practically? Practically, that means if you have a high transporter, after about 2 to 3 hours, you are getting no more bang for your buck, right? You're essentially having no more urea flux after 2 or 3 hours into the dialysate. At that point, you're getting mostly the downsides of fluid moving back to the patient. Okay, you're getting no more small molecule clearance after 2 to 3 hours, and you're starting to get more and more reabsorption of fluid back to the patient. Okay, so in general, you don't want to have those kinds of prolonged dwell times in your patients. Okay, so um, here are some typical total dialysate volumes in patients who have no residual kidney function that one can use. Okay, let's do a little bit of derivation. So you don't have to memorize this. You can actually intuit these things. You can devise at the bedside with a few calculations what would be an initial reasonable starting dialysis prescription for a patient based on your target KT over V. Okay, so let's go through some of this math. If you assume that this weekly KT over V of 1.7 is adequate, you can challenge that. But let's assume that that's the target that you're trying to achieve. Then simply dividing 1.7 by 7 gives you a daily KT over V of around 0.25. Okay. Now, you're going to assume, what is K? K is, again, a volume per unit time. That's what clearance is, right? Mils per minute would be a K that you are familiar with when you're prescribing hemodialysis or CRRT. When I'm prescribing peritoneal dialysis, often you can use a different unit system, liters per day. Okay, that allows for quick translation between Ks and my PD prescription, which is in liters per day, right? You'll prescribe 8 liters per day of peritoneal dialysis or 10 liters per day. That's 2 liter exchanges times 5 is 10 liters per day of clearance, right? Still a volume per unit time, okay? So you can assume, remember I told you, if I had a patient on CAPD and they had equilibration of the dialysate urea concentration with the blood urea concentration after 4 or 5 hours, one can say that if I did a CAPD, PD, right? And I did Q 6-hour changes, right? 4 times a day, Q 6-hour changes. You can assume that when I'm doing Q 6 hours, the DUN and BUN at the end of 6 hours is equal, right? I have equilibration after about 4 or 5 hours, okay? So what is clearance then? Clearance is simply going to be, you should be familiar with this when we've talked about CRT or even creatinine clearance is a urine creatinine over plasma creatinine times a urine flow rate, right? That's UV over P, right? That's the familiar creatinine clearance equation. Well, when I'm using DUN and BUN, I can replace this to this U and P with, okay, I can say instead of urine, I have dialysate urea nitrogen, right, over BUN. And this flow rate is simply the PD fluid that you put in and out of the abdomen. If DUN and BUN are equivalent with a longer dwell time, then my total clearance is simply how much PD fluid I put in and out of the abdomen in 24 hours. Okay, so with CAPD, with a Q6-hour exchanges, if I did 2 liters with each exchange, you'll know that your K24 is going to be about 8 liters per day. That's my clearance. That's K. Okay, if I then know my V, let's go back to this, right? If I know my V is, let's say, 35 liters, V is going to be total body water, I can do the math in order to ensure I'm achieving a K. T is 1 day, so I've taken the T out of there, right? K over V of 0.25, right? So let's do this. Let's again say I had 8 liters of clearance in that CAPD prescription. And let's say the patient had a volume of distribution of 32 liters. I would see that I've achieved my K over V of 0.25. That should be enough for this individual. Okay. Questions about that? So napkin math, PD prescription. Yeah. Yeah, so there we go. So if I have a patient who is receiving mostly nocturnal peritoneal dialysis, right? Just intermittent PD. Uh, Nocturnal PD is how we generally do that intermittent peritoneal dialysis. You have to add an additional 2 liters. Okay. So if I was doing, let's suppose I had this patient, they were not a low transporter. I don't know what their transport characteristics are, but I want to prescribe their PD primarily at night. Okay. I would assume that I do not have equilibration of DUN and BUN. And so I would be less than 8 liters of clearance. In order to bump up to about 8 liters of clearance, I'm going to empirically add another 2 liters. So if I'm doing shortened PD, mostly nocturnal PD, just empirically add another 2 liters to your total, K. All right. Assuming that DUN and BUN have not equilibrated. And this you'll find if you look at the Adequest tables. Remember, Adequest refers to that, you know, that tool that's out there online. I think you even have to pay for it. But if you find some of these Adequest tables, you'll basically see that play out. If you're prescribing, if you move someone from a more conventional CCPD or CAPD to nocturnal PD, you can see that the difference between those two is roughly 2 liters additional of volume in making that transition. Okay. No, so the question is, with tidal PD, would you have to adjust for that? I can't give you empiric knowledge about how much you would need to adjust, but you would definitely need to increase volume. The amount of volume you would increase would depend on what was your percentage tidal PD. If I had 95% tidal PD, you would have to increase very little. That would be akin to doing full PD. If, on the other hand, I have 50% tidal PD, you're going to have to crank that up quite a bit. Okay. I can't give you, though, the proportional increase. I would presume that if I had a 50% tidal PD, I'm not sure I would ever prescribe that, number one. But if I had to do it 50% tidal PD, I wouldn't be doubling my total volumes, but I'd be increasing it easily by a third. Okay. That would be my empiric, judgment call. Okay. All right, so I think we've sort of played this out. Here's an example again. If I had an anuric 70-kilo man, if you did their volume of distribution, that's 42 liters, multiply that times this 0.25 target, that would give you the total effluent needed during PD, right? So that would be 10.5. That's just 0.25 this target K over V, times 42 liters will give me the K, right? That's what I'm doing here. I'm simply solving for K. To solve for K, I multiply 0.25 times V, right? That'll give me my total of clearance in a day, liters per day, right? If I'm doing APD, or if I'm having an individual with low transport characteristics and I'm not doing quite a full 6 hours of dwell time in this individual, you'll have to add another 2 liters to their total flow. Okay. Now, if I have an individual with rapid transport characteristics or high transport characteristics, then I need to shorten dwell times, right? We've already talked about that. Okay. If I have an individual who has high transport characteristics, and I don't have significant residual kidney function, most of those patients also need some ultrafiltration during the day. Can't get by with just NIPD. Okay. CAPD with in a patient with rapid transport characteristics, I told you that will be maladaptive because as you're having prolonged dwell times, right, you're getting no more bang for your buck. You're getting downsides, essentially. You're having no more small molecule clearance. You're starting to have, again, reabsorption of that fluid into the patient. And so you would want to shorten dwell times by leaving the night, for instance, dry and just doing, let's say Q 3-hour or 4-hour exchanges during the day. Okay. If they have residual kidney function, obviously you're going to leverage that by giving loop diuretics. You may need to add more hypertonic exchanges, and then the addition of icodextran is a common intervention for those individuals that need that extra bump of ultrafiltration. Okay, moving on to peritoneal dialysis adequacy. Okay, I've already stated, I've put in writing, KT over V is not the end-all be-all of adequacy. Okay, so the other point to make is that residual kidney function is a more important clinical outcome predictor than total KT over V. Okay, that's been shown by a couple of studies. Residual renal function should be preserved if you can. Okay, by avoiding gentamicin in those with residual kidney function, limiting the contrast loads, etc. Okay. Now, again, defining adequacy should not be solely based on KT over V. If a patient is not feeling well, some would argue empirically increasing dose and reassessing the patient to see whether they feel better. Okay. The other, guess I'm here just reinforcing that KT over V is one measure of adequacy, not just a sense of wellness. If a patient has at least 100 cc's of urine, account for that residual kidney function for calculating KT over V or total KT over V. Okay, and a formula for calculating KT over V is provided here. You can see that I need the effluent volume, the urea concentration in that effluent, the urine volume, as well as the urine urea concentration. Those are in your numerator. The denominator has my plasma urea concentration. And then you can see where the V comes from, total body water. And then the 7 is translating these daily volumes into a weekly KT over V. So multiply times 7. Okay. So that's intuitive. One can drive that. You don't have to look it up. Again, it's just based on the same old, K is basically UV over P, right? This is UV over P. T is your time in days or weeks. V is your total body water. right? So again, you can refer to this formula, but you can also napkin math it, right? Okay, so volume control, I mentioned, is extremely important. So again, these are all components of adequacy: wellness, KT over V, volume control, other metabolic control, like their acidosis and potassium control. Um, One can consider adding phosphate control to this, but phosphate control is always so difficult and is a messy landscape. So I've intentionally left it out. Um, and then no signs of malnutrition. Okay, so I want to see my patients thriving. And there are measures of malnutrition, such as uh, 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 protein nitrogen appearance, which we'll talk about shortly. Okay, here is our peritoneal dialysis catheters. You may not have it, but it is there in future versions of the field guide. Very important, okay? Talking about these things, transfer sets and that sort of thing. Perhaps you had some confusion as an early fellow, but now know this. But this is the transfer set, okay? This is basically the patient comes out of the OR with often a plastic um, uh, I'll just call it a cap here, okay, a connector, I'll use that term. That connector is often changed in our dialysis clinic. That connector is compatible with a transfer set, but our dialysis clinic often changes that connector to, they call it a titanium connector. This is the titanium connector. Here it is on the Fresenius transfer set, right? You can see the same thing comes from the abdomen, the exit site, titanium connector, and everything distal to the connector is the so-called transfer set. Here's the Baxter transfer set. Here's the Fresenius transfer set. This Fresenius has this wonky mechanism. They call it the stay safe cap that basically allows the individual to not manipulate this by hand. They plug this into a, um, I'll call it a connector on their machine, and then they just twist a knob in order to basically connect this to a dialysate bag. There's no manipulation by finger. They plug this in again to a uh, to their machine, and then turn a knob in order to hook up to their bags. Okay, the presumption is that you're going to reduce risk of touch contamination with the stay safe cap. But when you have a Fresenius patient who comes in, you often need to take off this Fresenius cap and put on this Baxter transfer set. And then the patient needs to have this removed and put back. This Fresenius transfer set needs to be put back in order for them to do their PD at home again. So if you discharge a Fresenius patient with a Baxter transfer set on a weekend, that can be a problem, right? So you should be able to discharge them and say, you need to go to their PD clinic and they need to change this transfer set back to the Fresenius transfer set. Okay. All right. Complications of peritoneal dialysis. Um, I will say you can connect. I glossed over this. If you have a Baxter patient and they get admitted to a hospital with only Fresenius supplies, you can connect this Fresenius transfer set to the end of this Baxter transfer set and then take that off on discharge, assuming they have this mini cap. This mini cap is consumable. Okay. Every time the patient has a PD, they get a new mini cap. This has betadine on the inside. Okay. This, by the way, is just a Luer lock. Okay. You twist here in order to open it. But if, frequently, if you have a dysfunctional PD catheter and you see fibrin in there, you want to TPA this, you should have the courage to do that because often the nurse doesn't. Nurse says, no, I'm not going to do that. So I'll draw up your TPA. Okay, do that for me. I'm going to unscrew the mini cap. This is simply a Luer lock. I connect that syringe with the TPA in it to this. Okay, I twist this to open it. I inject the TPA. I need to replace this ideally with a fresh mini cap. Okay, put a mask on before doing that. Okay. You don't need a sterile gloves. Our patients are not using sterile gloves every time they do this stuff, right? They wash their hands, they put a mask on, and they do all this every day. Okay. All right. Peritonitis, as a complication, we'll cover first of peritoneal dialysis. Sometimes you'll have abdominal pain, fever. Very often you'll have cloudy fluid, not always. And then ultrafiltration can suffer. Don't forget about that. When you have inflammation in the peritoneum, it creates a leaky endothelium for the blood vessels that line the peritoneum. And so you often have a transition to more rapid transport characteristics. Ultrafiltration goes down. So that's a common way that patient can present as well. New volume overload without a drop in residual kidney function would be an example of how some patients can present with peritonitis. Okay. How do we diagnose peritonitis? We rely on at least two of the following: high cell count with polys, predominantly polys. Okay. We want that sample to have a 2-hour dwell. Okay. But you don't want that sample to have been sitting in there for, all day and mostly got reabsorbed. And now you have this concentration of cells in the peritoneum because you've lost dialysate volume as they've reabsorbed that fluid. Okay, so you don't want this to be a dry tap and taking a cell count. Now you can do that in order to exclude peritonitis. If you have a low index of suspicion, you're not going to give empiric antibiotics. You can say, okay, do a dry draw. And if the cell count is reassuring, even though they've had PD fluids in their belly for the last 12 hours, good, and it's negative for peritonitis, that would be reasonable negative predictive value, but just don't overdiagnose peritonitis from that. Okay?
So they can.
Yeah.
From that because.
Yeah, I mean, presumably you're saying that you won't have the reabsorption of icodextrin. That's true. So yes, you could do that. Whether I would be confident that a positive peritonitis test in a patient who had icodextrin all day in their abdomen. I mean, if I had a low index of suspicion, I think I would still say let's do a more standard sampling if I had a low index of suspicion. Okay. I think you're countering that. Well, if I'm not reabsorbing fluid back, if I simply had PD fluid in for 24 hours, is that still reliable? I would not sort of trust that. Okay? If I have a low index of suspicion, I would just redo it properly. Okay. We need some abdominal pain. We would need some positive PD fluid cultures. Now, you may not have all of these. We certainly encounter culture negative peritonitis is the term we use when PD fluid cultures are not positive. That can be related to technique. It can be related to the fact that they've recently received antibiotics. There are a number of reasons why patients may not have positive PD fluid cultures. Okay. Confounders in the diagnosis. We've talked about the dry abdomen. And there's also a phenomenon in which a fresh PD start would also tend to have pleocytosis in the fluid in the peritoneum. And sometimes that can have an eosinophilia or eosinophilic predominant pleocytosis in the PD fluid in a fresh start. Okay, and so don't overdiagnose peritonitis as well in a patient who's just started PD. Okay, the incidence is roughly once every other year. Okay, or so. Peritonitis once every other year in a patient would be fairly typical for a patient population. The micro is typically these skin commensals, right? Staph epidermidis, Staph aureus are many of the GPCs that you see. Okay, you could also have the um, the streptococcal bacteria as well. Okay, also skin commensals. And then you may have gram negatives as well as the culture negative patients as well. Okay. Prophylaxis, where you'll potentially try to prevent peritonitis. Um, Here are several indications for possibly using prophylactic measures. If I have a patient who's on prolonged antibiotics for osteomyelitis, for instance, you might add fluconazole for oral fluconazole for fungal peritonitis prevention. Okay. The data for using prophylaxis for dental procedures and colonoscopy, similar to, for instance, endocarditis prophylaxis, is very weak, but I would say is still done in many cases in preparation for a dental procedure. A dose of amoxicillin, again, similar to what you saw for of endocarditis prevention in a patient with valvular disease. Colonoscopy, you would want to cover gram negatives as well. So amoxicillin or ampicillin plus Cipro would be an example of a strategy that you might employ to prevent peritonitis in a patient that is going to colonoscopy. And then anytime your patient has a identified break in technique, it would make sense to also prophylax the patient. So many times patients come into the PD clinic when they say, "Ooh, I noticed I touched or I dropped it and it landed on my bed while I was trying to do an exchange." Many times those individuals will have a dose of Vanc given to them. Okay?
One dose of Vanc now, or dose of
Generally, yes. Yeah. Right. And don't forget, a dose of Vanc can hang around for a week, depending on the residual kidney function. Okay. So a dose of Vanc is really a week of Vanc. Okay. All right. So let's get to the end of this section and then we'll end. Treatment of peritonitis generally relies on a minimum of 2 weeks for coag negative staph and 3 weeks for others. This comes from the ISPD guidelines. Okay, so 3 weeks. You can see that there's some flexibility here in the actual practice, but the ISPD guidelines would say 3 weeks of coverage would be standard unless it's coag negative staph. Okay. Certainly, these can be managed as an outpatient, even though you may have encountered the bulk of your peritonitis experience in the inpatient setting. You absolutely can manage these as an outpatient, similar to how you can manage HD catheter-related infections as an outpatient as well. You may never see those. Most of your experience may be in the inpatient management, but you can manage these as outpatients. You typically prefer IP antibiotics. You provide that IP dose in at least a 6-hour dwell. That increases the local concentration of the antibiotic in overcoming that infectious complication. That being said, don't delay therapy in somebody who's toxic. Give them IV Zosyn and IV Vanc if they're sitting in the ED and nursing says, I can't give IP, we'll have to wait to a bed assignment. Okay, and I can't get you a nurse now. If you see a patient who's toxic, you've already sampled the fluid, you should get antibiotics going, IV antibiotics going. Okay. Inpatient, yes.
Does peritonitis generally sepsis and like generalized toxicity, or is it mostly like
In general, no. And that's even in Ramesh's lecture, it's very unusual to have sepsis from peritonitis, but you can have, I mean, bad sepsis or bad peritonitis and have somebody with Staph aureus in their belly and look pretty shocky. Yeah, it would be atypical, but still possible.
For septic patient, can we use the IP and the delivery method to deliver the systematic antibiotic if they have no IV access?
Yeah, so the question is, can you treat somebody's, I guess you're saying pneumonia with, if you happen to have given them vancomycin, will you be treating that? Yes, because you can recall that, you're checking vanc levels in the blood and you get therapeutic levels in the blood. So theoretically you can do that. And in rare cases, we've gotten people with osteomyelitis who are on peritoneal dialysis and have problems with getting a PIC or some social problem with getting IV antibiotics, where we've decided to give them IP antibiotics to treat their osteo. Now, the VANC is let's say easy or easier to convince ID to go along with because you measure levels. But when you're also giving Vanc plus cefepime and you can't measure the cefepime, that's when they shut you down, basically. They say, no, I'm really not comfortable with this. Okay, but I've certainly, when I have a drug, an organism, and it's Vanc susceptible and everyone's okay with Vanc, you can make a pretty strong argument. Let's just do IP Vanc and we'll monitor levels. Okay. If you have somebody with residual kidney function, we talked about minimizing aminoglycosides. If you have a fluid that's pretty cloudy and sometimes you can actually see the fibrin threads in the PD fluid, you might empirically add heparin at a concentration of around 500 units per liter to reduce the chance of having these alarms and unsuccessful PD throughout the night. You might consider resending PD fluid after 2 days of therapy to just ensure that the cell count is decreasing. If a patient is not doing well, you might need to remove the catheter. What would be examples of not doing well? Well, their cell counts are still high. They're not clearing the infection in the peritoneum after 5 days of therapy. If I have a tunnel infection looks very similar to the tunnel infection of an HD catheter. Really doesn't look any different. Don't be shy about taking that dressing down. You should be doing that. Anyone with a concern of peritonitis, you should be looking at the catheter. You should be trying to milk pus out of the tract. And this can be a clinical diagnosis. You do not need an ultrasound to look for pericatheter fluid collection. Okay. I've certainly had, let's call them teaching moments with fellows who missed a tunneled catheter, and then I brought them back to the bedside and we milked the catheter together, and this tremendous spurt of pus comes out of the tract. Okay, so you should be looking at these tunnels. Okay, if I have peritonitis within 4 weeks with the same organism, that is a treatment failure. That would be an example of treatment failure where you'd consider, again, removing the catheter as a fomite. And then if I have these really, bad bugs, fungal or AFB peritonitis, most would just say that catheter needs to go at this point. Okay. Empiric therapy generally requires similar drugs for the CLABSIs. You generally cover GPCs and Pseudomonas, and then you use Vanc when your center-specific prevalence of MRSA is relatively high. Okay, so here in this treatment site or in our sites, we have reasonably high MRSA rates. So most people need Vanc and an anti-pseudomonal. Ceftazidime, cefepime would be typical anti-pseudomonals, aminoglycosides if you don't have residual kidney function. Okay, if you don't have MRSA, at high levels in that that center, you can use cefazolin and cefepime or ceftazidime or cefazolin and another anti-pseudomonal. Once you get the organism, you tailor treatment, some special considerations. ISPD guidelines suggest using rifampin as a synergistic medication if you have Staph aureus peritonitis. I don't see us do that very often, but this comes from ISPD guidelines. And then Pseudomonas, you might consider using 2-drug therapy. I would say this is really not commonly done. Okay, again, even though it's in ISPD guidelines. Okay. Any questions about that before we end?